intra-meeting questions from last week. So, I mean, from yesterday. Doesn't seem like it was just half a day away. All right, so I am going to read out the questions. Let me see. I think we already have quite a few of the participants on the line. Hopefully, you all have had a chance to review these questions, but if not, it's going to be reviewed for everyone. And then we'll go over our case study that we talked about right before the end of the class, and we'll go from there. Okay, so the first question was, with the exception of bipolar disorder, most depressive disorders are more common in men than in women. And so for those of you who are on the line already, if you could, we're not going to do a poll, if you could just type in the chat box whether you think that is true or false. So with the exception of bipolar depression, most depressive disorders are more common in men than in women. Cool. Great job so far. You're absolutely right. Most depressive disorders are more common in women than they are in men. So, and bipolar disorders incidence is equal in both sexes. So, thank you for your answers. The second question, men are more likely than women to disclose problems with alcohol use to their healthcare provider. Another true and false question. Men are more likely than women to disclose problems with alcohol use to their healthcare providers. So go ahead and type in your responses to that one. We have a fair amount of false responses on that answer. The answer is actually true. Men are more likely to disclose problems with alcohol use to their healthcare providers compared to women. That doesn't necessarily mean that they all disclose, but in comparison with women, men are more likely to disclose alcohol and other substance abuse related problems. Question number 3 is, I'm just going to give the answer because it's really, it would be really hard to read out all the choices, but it says, the question says, with regards to the role of hormones, including hormone replacement therapy, it is critical for a pharmacopsychologist to be aware that the correct answer in this case was C, estrogen increases water and sodium retention. So with regards to the role of hormones, including hormone replacement therapy, it is critical for a prescribing psychologist to be aware that estrogen increases water and sodium retention. And if you recall from our discussion yesterday, progesterone has the opposite effect in that it increases water and sodium elimination. All right, question number 4. Exacerbation of symptoms of the following disorders can be observed in certain women during the premenstrual period of their monthly cycle, except for. And 4 depressive disorders were listed. I am going to go ahead and read them out because they're easy. One of them we did not discuss at all, so hopefully you'll notice that would be the exception. Major depressive disorder, generalized anxiety disorder, dissociative identity disorder, and bulimia nervosa. So once again, exacerbation of symptoms of the following disorders can be observed in certain women during the premenstrual period of their monthly cycle, except for major depressive disorder, GAD or generalized anxiety disorder, DID or dissociative identity disorder, and bulimia. Cool. So a lot of you who have responded are choosing C, which is the dissociative identity disorder. Great, you found the right answer. Question number 5, the most commonly used teratogen affecting human embryos is, the A was lisinopril, an ACE inhibitor, B was alprazolam or benzodiazepine, C was alcohol, and D was lithium. The most commonly used teratogen affecting human embryos is lisinopril, alprazolam, alcohol, or lithium. Okay, got a few responses for C, and that is absolutely correct. If you pay attention to the keywords on the question, the most commonly used. So by all accounts, alcohol is probably much more commonly used than any of the other um, teratogens that were just listed on the question. And last but not least, the last question is right there in front of you in the chat box. Exposure to SSRIs early in pregnancy may decrease the risk of autism spectrum disorder, according to a Kaiser Permanente study. And I know we didn't get that far yesterday, but if you take your best guess, true or false, exposure to SSRIs early in pregnancy may decrease the risk of autism spectrum disorder. And you were all right. The correct answer is false, which we're going to discuss a little bit later on. Excellent. Thank you for participating. And with that, let me go ahead and share the screen. Maybe. Here we go. Okay. All right. I'm going to move this out of the way. Okay. Can everybody see the screen where being set to intermediate questions day 1, which is slide 158?
Yes, I can see it.
Excellent. All right. Let me also make sure I can see the chat box as we continue to, oh, sorry about that. Okay. Pardon me while I move things around a little here. Okay. Very good. All right. So that was the start. That was the start today was a review of the questions. Thank you all for participating. But now we're going back to our case example. And I want to make sure that everybody is able to see the chat and get on the chat. I'm going to review the details of the case example that I left you with last night. And again, the goal was to get you to think about possible assessments that you might want to order, and also treatment considerations. Our case was that of Jessica, a 26-year-old woman with a history of bipolar 1 disorder, most recent episode depressed. She had experienced one severe manic episode where she stayed up for days in college at about the age of 21. During that time, she was irritable and ended up almost jumping from an overpass onto train tracks with an incoming train, but was stopped by a classmate. So this was a suicide attempt interrupted by others. Now, Jessica presents for treatment, again, as a 26-year-old, has been married for about a year, has been symptomatically stable with no depressed symptoms for over 2 years, and no manic symptoms for at least 3 years, and wanting to conceive. She is currently on unopposed antidepressant therapy, meaning no mood stabilizer is on board. She was taking 40 milligrams of citalopram daily with 50 to 100 milligrams of trazodone at night for insomnia. She her husband, some psychosocial factors that are important for you to know are that her husband, new husband as of about a year, is frequently deployed with long absences from home. She is geographically located close to the husband's family, with whom she doesn't really get along, and is geographically separated from her own family. She's also underemployed. She's working part-time only as a nurse's aide, and wants to go back to school and obtain her nursing degree so that she can be employed, fully employed. And she's also obese at about 37% BMI, and engages in very little physical activity outside of her work. So with all of those facts, I'm interested in your thoughts about assessments and potential recommendations that you might want to know or might want to do, might want to implement for this patient. Carmen says, I'm not convinced about the manic episode. No more episodes despite no treatment. Does she have a history of substance use? She did have subsequent manic episodes. The most recent one was at age 23. And to give a little bit more clarification, she'd only been on the citalopram alone for about a year, which is when she told her PCM that she wanted to conceive. So they took her off the mood stabilizer about a year before she started care with me. But we do, excuse me, we did have some, by her report at least, some significant evidence of um, um, manic episodes up until the age of 23. But that's a good point. No history of substance abuse, at least non-reported. We did baseline labs, liver functioning, as well as a urine drug screen, and there was nothing significant. Joy says, why is she coming in? Sounds like everything has been stable. She's coming in because she wants to ultimately get off the medication so that she could have a successful pregnancy. Brady says, client appears stable. I would suggest a taper off the meds with increased psychotherapy support to see if her stability persists and she can consider pregnancy. Increased social supports will be helpful given the access to immediate family support. Very good points, for sure. Wonder if anybody's looking more broadly at some of her medical picture. Her weight, yes, absolutely. And what, with regards to her weight, what may be complications during pregnancy for her or for the baby? You're absolutely right. Gestational diabetes. So this is a woman who is at high risk of gestational diabetes. She's also at risk, Brady's right, of high blood pressure, hypertension. From health at every size perspective, I would be very careful in regard to weight and weight stigma. Absolutely right, and agree completely. However, you would want to provide some education and certainly to make sure to improve the chances of her carrying full pregnancy to term without complications. Um, I also mentioned she engages in very little physical activity. Um, that in and of itself is not necessarily significant, although when it comes to the recommendations that Brady was making with regards to increasing psychotherapy support and social supports, et cetera, from a health perspective, would we want to recommend just increased or improved health behaviors in general? Would she have issues getting pregnant due to obesity impacting estrogen? If I remember right, increasing stored estrogen, that is certainly a possibility. We do see problems with pregnancy or fertility associated with obesity, and that could certainly be a factor that plays into that. Najib says, I would agree psychotherapy and weaning her off her meds would be a good option. I have concerns about postpartum, says Angela, very, very important. Um, so educating her about this possibility. Yes, what I'm hearing from a lot of you guys is about, psychoeducation, counseling, making sure that she's aware of all the possibilities that may be at play. She needs a support network. I would agree with that completely. And I don't know if you guys have heard of this trend, but at least in some of the military settings in which I have worked, we have seen over the past few years a trend toward prenatal visits and prenatal counselings happening in a group setting as a way to facilitate a support network right off the bat, because many of our moms are new spouses, you know, from military members, or maybe new arrivals to the installation in which they find themselves without any other extended or social support, family support networks. And so this is a good way to improve not just a social network, but also facilitate communication with other moms. Could we consider Zoloft if depression comes back during pregnancy? Yes, indeed. And in fact, we could consider restarting Celexa if necessary. What about Latuda if she needs a med? Great point. And actually, this case preceded Latuda. So I'm glad you bring that up, because now we have we now have a medication that is relatively safe in pregnancy and could be used for mood stabilization. So that's a good point. Rebecca says, is new husband on board with pregnancy? Yes. And that they actually both attended at least one session with me to discuss the potential risk versus benefits of treatment during pregnancy. I'll tell you more about the case as we finished our discussion. Would we see her more frequently while pregnant? Yes, absolutely. And again, establish any other sources of support, including groups or psychoeducational classes, or moms networks, or anything else that could facilitate that. So one thing that it's important to consider in a case like this is that it sounds like you all are very clear on the fact that we would want to taper this individual off her medications, and it would be appropriate to do so based on the fact that she has been clinically stable and asymptomatic for some time. The possibilities to consider or not is whether she might develop a manic episode in pregnancy. As I mentioned before, pregnancy can bring about a destabilization even for women who have been asymptomatic before, and certainly much more likely for that to be the case for a woman who has a history of a significant mental illness. So we want to consider the possibility that if that she could become not just depressed but manic during the pregnancy. And in that case, can anybody throw out some ideas or thoughts about how we might have to treat that? Sounds like she would need a solid safety plan with her. Absolutely. And part of that safety plan is making sure not just that the husband is on board, but that he is planning for potentially being around for during the time that she is pregnant, or at least for a significant part of her pregnancy, so that she's not on her own. Maribel says no lithium. You're absolutely right. Kirsten says depend on the trimester for meds and neural tube defects, etc., from lithium and neuroleptics. Yes, correct. So yes, no lithium would be the goal. First therapy of choice for bipolar mania during pregnancy, and we haven't gotten to that point yet, so this is a little bit of skipping ahead. It would be the second generation antipsychotics. And in that case, and in any case, say we needed to have a mood stabilizer on board, unlikely, but at least for the treatment of bipolar, but possible for women who suffer from seizures, etc. One of the ways that we know that we can prevent neural tube defects is with potentially with the use of folate or folic acid. And so we want to make sure to assess for folate levels. We want to make sure to increase, to start her use of prenatal vitamins. And, as I mentioned before, as part of counseling, that includes information about a lot of health behaviors. In her case, let's see, does anybody have any questions or ideas or any other thoughts you want to throw out there? Joyce says, I have a client who is considering going back on Lamictal when she gets pregnant to manage bipolar. That would be the impact of this. What would be the impact of this? Hold that thought, because we're going to talk about it at length. Not ideal, certainly not ideal. So this client requires a lot of medication, a lot of counseling and to be able to make an informed choice. So I don't want to not answer your question, but I want to make sure we hold off, because you're going to hear a lot more about this in the next few slides. The other, other considerations, again, when we talk about gestational diabetes, we want to make sure that the patient is aware of the risk potentially. We want to, in her case, one of the biggest things that was important for us to manage was her sleep. And, you know, if you look at retrospective data, one of the biggest predictors of a manic episode is periods of poor sleep, poor or broken sleep. And so we decided, in the interest of her, in the interest of maintaining her stability, that trazodone was necessary for her to maintain. Even while she was trying to conceive, we added folate or folic acid and a prenatal vitamin to her diet. We counseled her about the potential use of fish oil and other DHEA or omega amino acids for mood management, and also for, you know, other benefits like heart health. We talked about physical exercise, nutritional counseling, and referred her appropriately. And this was with her consent, of course. It was not, you know, it was not an attempt to you know, essentially override all of her wishes or desires, but, you know, to help her get as healthy as possible, which was her stated desire before having a pregnancy. We tapered off the citalopram, as I said, maintained a trazodone, provided you know, referrals for nutritional counseling and other social support networks. And in the end, I think I treated this young lady for about a year, and by the end of the year, she was able to conceive. So I wish I could tell you whether or not she experienced a manic or depressive episode during pregnancy, but they either I moved or they moved, as it often happens in the military setting, and I did not continue her care. Joy says, now that you mentioned sleep, I'm worried about what she's going to do after the baby is born. Are in-laws able to help? Will husband be around? Those are very important considerations. And that was part of the education that we provided to her husband, that we needed to make sure that she had a very protected and stable sleep schedule, that in discussing whether or not he would be around to help her with the new baby, and, you know, what sort of mechanisms would be in place. Those are all very good points. And we definitely wanted to make sure to take those into account. And of course, as one of you mentioned before, postpartum depression, or even postpartum mania in with psychosis, are considerations, you know, for somebody like Jessica. And so we also wanted to make sure to, you know, provide education ahead of time, just in case those things were to happen. Would husband even have the option to be around? Potentially. I mean, it does depend on the job that they're in, but there are folks who can volunteer for a non-deployable billet, or change positions, or do, you know, a special duty assignment or something like that, in order to be able to provide more stability. The other option that they had was to request a move that was closer to her family of origin, in order to garner a little bit more support for her if he was to be gone. So that is, it's not a guarantee, but it's certainly a potential. All right. Well, thank you so much for your inputs. Again, lots of thoughts, lots of good thoughts, and lots of ideas and treatment considerations that happen just as, you know, you receive a case for something as simple as, you know, I have bipolar disorder and I want to get pregnant. And so I'm glad you guys are thinking, about these issues, and, really appreciate all of your inputs. Carmen says for federal employees, a new benefit of 6 weeks and leave for males and females having a child, including adoption. That is correct. And actually for active duty members, mothers have she's not an active duty member, of course, but mothers have what we call convalescent leave, which in the past would have been the maternal leave after childbirth, and now there's an additional caregivers leave. So her husband would have the opportunity to take those 6 weeks of caregiver leave in order to be able to assist both the mother and the child. So his wife and his child. All right. I think this is where we left off yesterday. So want to give you a little bit of a review. You guys, so it doesn't seem so out of the way there. If I go back to slide number 138, I want to emphasize to kind of be on the lookout for some of this potential pregnancy problems associated with antidepressant medications, which you're going to see to varying degrees depending on the class of medication. So as I mentioned before, all antidepressants could be associated, doesn't mean they are, but they could be associated with neonatal persistent pulmonary hypertension, which you were seeing a picture of before, neonatal serotonin syndrome, which would be, exhibiting symptoms that are consistent with too much serotonin, neonatal withdrawal symptoms, which would be could be the potential effect of having a mom using a serotonin drug in the third trimester and not appropriately, not tapering off or not, tapering off before delivery, low birth weight, and premature birth. And yesterday we explained pulmonary hypertension. So we're going to talk about that, which I didn't get to show you yesterday, but that you got in some of your inter-session questions here just this morning. Exposure to selective serotonin reuptake inhibitors in early pregnancy may modestly increase the risk of autism spectrum disorder, was the finding of a study by Kaiser in 2011. I have looked and I have not seen replication of the study. And so this is just one study. I want to emphasize that it does, highlight, it was a good number of subjects, and I don't remember, and I don't think I've written it on the slide, but they did report a twofold increased risk of autism spectrum disorders associated with treatment of the mom with SSRIs during the year before delivery. So not just during pregnancy, but during the year before delivery. I'm not exactly sure what to make of that, but certainly it's something that you need to be aware of and potentially make your clients aware of, especially if they already have a history of autism spectrum disorder in their families. It seems the strongest effect was associated with treatment in the first trimester, and we've already talked about the complications of drugs that could affect the baby or the fetus in the first trimester, and that is, potentially that at least, that it could be half, that the mom could spend at least half of the first trimester not knowing that she was pregnant and potentially exposing her child to the substances. So again, one study, one finding, not necessarily replicated in other studies, at least that I could find. For other antidepressants, yesterday we got to talk about TCAs. We talked about MAOIs and SSRIs, which we're just concluding. Others, such as the SNRIs, the NDRI or DNRI, both are equally correct. We pretty much have similar warnings, risk of teratogenicity not expected with mirtazapine based on limited data, would expect risk of neonatal withdrawal symptom or serotonin syndrome based on human data with SSRI specifically. With venlafaxine and duloxetine, risk caution advised during the third trimester. And again, but if you think about it, based on the mechanism of action and the effects of withdrawal from these medications, that's why you'd want to be more cautious during the third trimester. Let's see what else. Some of the other ones you need to know about: bupropion, caution advised, risk of congenital heart defects is inconclusive, but no known risk of teratogenicity based on human data. For trazodone, again, you would expect similar effects as you would expect with any medications that affect the serotonin axis. And yet you want to be, cautious about its use, especially in this case in the third trimester. I do have a slide on the newer antidepressants, but before we talk about that, as far as others, and I think all really, what we want to do is encourage patients to enroll a national pregnancy registry for antidepressants. The information is listed there, both their toll-free number and their website. And understand that there's relatively little data available, and so in general they are considered relatively safe to use during pregnancy, but of course we want to make sure to provide psychoeducation to both the mom and ideally her partner if possible, and to weigh the pros and versus the cons, and determine the best and most conservative, I would say, course of action when it comes to treatment of depression in pregnancy. One thing that I would add is, as I mentioned yesterday that women of reproductive age are, routinely excluded from pharmaceutical trials. And if not, for sure, pregnant women are definitely excluded from pharmaceutical trials. So a lot of the information that we have about the effects of medications during pregnancy, for very good ethical reasons, comes from post-marketing studies. So, studies or case studies specifically that may have come about after the drug was marketed to the general public. And so for that reason, it's important to point out that this registries, I guess what I want to highlight here is the idea that this registries are a very important source of information when it comes to post-marketing studies or post-marketing cases, because we wouldn't otherwise know this information based on the trials, the phase 1 and phase 2 trials that are done before the medications receive approval. It's also for that reason that I think I'm not sure if you guys have had a course with Dr. Salmons just yet, but one of the things that he emphasizes in his integrated therapy course or integrated pharmacotherapy and psychotherapy course is something that I will never forget and have continued to use to this day, which is don't be the first person to try a new medication or the last one to give one up. I think once again, based on the knowledge that pharmaceutical trials do not involve a broad sector of the population, especially do not involve pregnant nursing women or even women of reproductive age, it's really a good idea to be conservative and wait for this post-marketing data to be available and for more information to come in before we start prescribing medications to pregnant or nursing moms. All right, I'll get off my soapbox. on that and talk a little bit about the newer antidepressants. So, uh, Viibryd is considered an other antidepressant, although the effects or the expected effects on moms and babies uh, are also expected to be SSRI-like. And so you can see for yourself, caution advised in the third trimester, risk of neonatal withdrawal or serotonin syndrome is expected, potential risk of pulmonary hypertension, or autism is inconclusive based on human data with SSRIs. For Fatsima, which is more SNRI-like, once again, risk are, the labeling is pretty similar to other medications in this class. And once again, I would advise don't be the first one to try this medications, or the last one to give up the old ones. With regards to lactation, which we're going to talk about later, so I just inserted this as specific to Fatsima. It does, the labeling does say to consider an alternative, although no human data available to assess the risk of infant harm or effects on milk production is available. That's just it. There's no human data available. And so, we probably want to go with safer options, that what we know to be safer options, as opposed to jump to this medications right off the bat. Trintellix is pretty similar to the other two, so we won't dwell on that. And once again, for lactation, safety unknown. And again, this is simply because they just have not been in the market long enough for us to have enough data to report. All right. So I want to highlight the fact that we use antidepressants to treat depression. I mean, that goes without saying, but we also use them for a heck of a lot of other things. And so you might not be the one prescribing the antidepressant, but it may be your patient who is taking an antidepressant for another use, whom you have to educate about the potential effects of using this therapy during pregnancy. So obviously for psychiatric conditions such as unipolar and bipolar depression, but those are an oversimplification, because we also treat, premenstrual dysphoric disorder and seasonal affective disorder, as well as a lot of quote unquote NOS, or unspecified depressive disorders, and even an adjustment disorder with depressed mood. Anxiety disorders, which you could see listed there, post-traumatic stress disorder. If, a lot of the SSRIs, most of the SSRIs actually are FDA approved for the treatment of post-traumatic stress disorder, and some of the SNRIs are FDA approved as well. We use the TCAs, trazodone and mirtazapine, or Remeron, to treat insomnia. We commonly use the TCAs to treat enuresis, at least in children. But you might see that with adults as well. I've seen people who have, significant urinary urgencies being treated with TCAs as well. Eating disorders, anger, aggression, impulsivity, compulsive sexual behaviors, but also, again, a lot of other conditions that may fall out of the realm of psychiatry or traditional mental health, including pain disorders, fibromyalgia, migraine prophylaxis or prevention, Parkinson's disease because of increase in of dopamine in the striatum. And so once again, at least for the four latter uses, it may be, oh, by the way, other, I mentioned pain disorders, other, including other neuropathic pain conditions. I think it's really important, again, to be keenly aware of what your therapy patients, are taking, both from mental health prescribers as well as from their primary care managers, internists, neurologists, etc. Because once again, they may only spend 15 minutes with the patient, but you know them well, and you might be the first person to be able to provide them with appropriate pregnancy or pre-pregnancy counseling about the use of this medication. And along those lines, I do want to say that one of the postings to Moodle associated with this class is a journal article from the American Psychiatric Association and the American Academy of Obstetrics and Gynecology, which combines all the knowledge that we had at the time. And I think it was printed in 2012. Again, I've not seen an updated version of it with regards to management of depression during pregnancy. And so to me, that is the gold standard when it comes to medications and medication education to patients. And I often take have the journal article at hand and make sure that I go over, information on the article with clients. Sometimes I even give them a copy of the article if they're interested in that. And then I document in my note that counseling happened in accordance with the guidelines provided by the American Psychiatric Association and the American Academy of Obstetrics and Gynecology, so that from all perspectives, all the bases are covered. Okay, we have a question from Carmen. Have you ever dealt with someone already pregnant who wants to come off their meds? Yes, absolutely. And again, it could be along the lines of someone who's just discovered that they were pregnant and they were on meds and wants to get off as quickly as possible, or somebody who's coming in, halfway throughout their pregnancy and decides, they've been stable enough and they definitely want to give up their medications before they deliver. And one of the things that we're going to get to later on is how I try to provide trimester by trimester, and sometimes a little bit more closer, advice as to whether we think that's an appropriate thing to do, and we manage those with the alternatives as much as we can. And we will have a whole slide on some of the alternative ways that we can manage depression during pregnancy. So yes, I have helped women taper off their medications during pregnancy, for sure. All right, we have our first poll question this morning. So let's go ahead and post that right now. And then we'll start talking about the mood stabilizers. Aiden, can you help me with the poll question?
We go with all the above.
Here you go. Thank you. All right, I think we got just about 83% of folks who have voted in. So we'll be closing the poll. All right. Uh, Thank you to everybody who responded. Let me go ahead and share the results. So the question is, your professor did not advise which of the following with regard to pharmacotherapy with pregnant and nursing women. The correct answer would be C. To avoid, we've already, although I haven't clearly or specifically said this is not necessarily the best course of action, we've already talked about the fact that the reality is that some women will need to be on medications. Even when we talked about the case example, we talked about the fact that it is possible that our patient may develop depression or mania and will need some sort of treatment during pregnancy. And so our goal for sure is to document, educate, and assess and reassess. And one of those ways that we reassess is assess every trimester whether there's still a continued need for medication, because once again, ideally, if we can skip medication during the first trimester, potentially bring it back during the second trimester and either taper off or discontinue completely during the third trimester, then we've already improved the clinical picture both for the mom and minimize the risk for the baby. So good job. Thank you for participating. And let's go ahead and continue. All right, so we are now on slide 159. As I said before, we're going to start talking about the mood stabilizers. Okay, let me, okay, close that. All right, so the first one, of course, the gold standard for treatment of bipolar mania is lithium. We would definitely consider this to be a medication that we want to avoid if at all possible. Consider, the warning label. It used to be a category D, and again, as you recall, category C was, weigh the risk versus the benefits. If, the benefits outweigh the risk, it's relatively a safe drug to use. Category D would be avoid unless you don't have any other options. Category X would be avoid no matter what. So lithium, therefore, is one that we definitely want to avoid. The biggest risk associated with lithium use, and this is something you should know about, is cardiac issues. Lithium is associated with something called an Epstein's anomaly, which we will talk about later on, but this is likely to be something that you may see on the PEP, so I would definitely remember that association between lithium and cardiac effects, specifically Epstein's anomaly, and the fact that using lithium during pregnancy requires you to get a fetal EKG at about week 16. Okay, baby registries have been established in Denmark, Canada, the US, and resulted in something called the International Register of Lithium Babies. So there has been long-term follow-up for some of these cases of, what I describe as lithium babies. I've already mentioned that lithium can produce this cardiovascular malformation known as Epstein's anomaly, which we will see in the next slide. And what we would recommend is that women be tapered off lithium, and if necessary, restarted after the first trimester. So this is, again, understanding that reassessing, whether the need for treating the bipolar disorder is more urgent than, being able to maintain the woman medication free throughout the pregnancy. Again, currently, the gold standard of treatment for bipolar disorder in pregnancy is the second generation antipsychotics. But if you have a woman who has not responded to any other treatment except for lithium, then the possibility of reintroducing it as necessary after the first trimester is still left open. So this is a representation of the Epstein's anomaly. As I said before, it's a cardiac malformation. What you have is a normal heart on the left and a representation of the Epstein's anomaly on the right. And this middle part here between the um, the right atrium and the left atrium. So this would be the right atrium over here, and the left atrium is ASD is the type of anomaly that you would see, and that would be an atrial septal defect. So ASD, Epstein's anomaly, is considered an atrial septal defect, and that is again something that is unique to lithium and some benzodiazepines. You could also see, and when you compare the right ventricle and the left ventricle, that the left ventricle in a normal heart versus in Epstein's anomaly is much larger. What you would see, and you, again, you want to know the association between lithium and Epstein's anomaly. I don't think the test my test or the PEP is going to ask you for details about how it might represent. But yes, we see this in the infant, and what you might see is symptoms that develop very quickly after birth, where the baby maybe have bluish colored lips and nails due to low blood oxygen levels. And in severe cases, the baby could appear very sick and have trouble breathing. Symptoms, milder symptoms in children may include a cough, failure to grow, fatigue, rapid breathing, shortness of breath, fast heartbeat, and of course the treatment would depend on the severity of the symptoms. This is the reason that we do recommend an EKG at week 16, because we often would see that these babies are going to need care right after delivery if they present with this atrial septal defect. And so this is a good, the EKG is a way to prepare the family and also prepare the healthcare provider for the delivery of this baby. All right, with lithium, I mentioned the fetal echocardiogram should be done. Specifically for women who have had first trimester exposure. And if you remember going back to the chart that talks about the critical phases of development or critical periods of development, that's, it'll make sense why this happens in the first trimester. There are some physiological changes that happen that may affect the metabolism of lithium, including changes in the glomerular filtration rate, or GFR, and potential for dehydration during labor and delivery. And not only that, but potential for dehydration overall. As you probably know, one of the most potentially most bothersome, not necessarily dangerous, changes in pregnancy is that women have an increased need for urination, and therefore you may have a mom who may be underhydrating in an effort to prevent having to go to the bathroom every 30 minutes and that sort of thing. So that would definitely complicate the picture with regards to being able to use this medication. The neonate may be at risk for lithium toxicity at serum concentrations that are lower than that of the mother. Obviously, they have underdeveloped organs, and so if the mom is still taking lithium at delivery, those levels may be toxic for the baby. Lithium toxicity presents with a syndrome that looks like it's described on the slide. Flaccidity, lethargy, and poor sucking reflexes are seen, and those may persist for more than 7 days. We do see reversible changes in thyroid function. We can see cardiac arrhythmias, hypoglycemia, and diabetes insipidus is possible, and hypoglycemia. I'm sorry, I've said that already. And yet, in some of these baby registries or lithium registries, the evidence has shown that there's no neurobehavioral sequela after several years. Let's see what else I want to say about that. I think that's all we're going to say about lithium. Again, in short, If you can avoid it, do. If it cannot be avoided, try to avoid it during the first trimester, and certainly consider tapering off before delivery of the baby. For other, well, actually, before we talk about the mood stabilizers, I'm noticing it's 5 minutes before the end of the first hour. So maybe this is the time for our first break. Let's go ahead and take a 10-minute break, and we will be back 5 minutes after the hour. So we covered lithium already. We're going to start talking about the mood stabilizers. And by that, I mean essentially the anticonvulsants. Um, what we know is, in general, these medications are contraindicated in pregnancy. Most of them have been were previously categorized as category D, meaning avoid unless you have no other alternatives. Which again, keep in mind that for women who suffer from seizure disorders, there may not be other alternatives, but for women with bipolar disorder, we do have some. In utero, carbamazepine and valproic acid increase the risk of congenital malformations, specifically in the category of neural tube defects, of which spina bifida is one example, and I'll show you some pictures in the next slide of what that means. Let's see, you see a notice from the FDA that women taking anti-seizure medication or related products have an increased risk of lower cognitive test scores than children exposed to other anti-seizure medications during pregnancy. So this was specific to valproate and valproic acid, or the valproex sodium specifically. Growth retardation can also occur with valproic acid, and we see an increased risk of cleft lip and palate with topiramate. Let's see what else I want to tell you about that. Again, for the most part, these medications were considered category D and are now relative contraindications during pregnancy. This is where a neural tube defect may look like. In the first graph on the left, you see spina bifida occulta, meaning hidden. So it's not visible to the plain, at plain sight. Whereas in the future slide, you see what it looks like when it's not hidden. And then you have two other examples of neural tube defects that may be present at birth for the infant. And as I mentioned before, this is what it looks like when it's not hidden. It would be plainly seen for, in a baby at birth when it's an open defect. Let's see. Okay, other issues associated with mood stabilizers or with other mood stabilizers. For carbamazepine, weight, the recommendation is weight the risk versus the benefits during pregnancy. Recommend folic acid supplementation, especially in the first trimester. And I think as a rule, you would want to recommend folic acid supplementation to most pregnant women. Risk of teratogenicity is present based on human data, and possible risk of neonatal withdrawal symptoms. Based on limited human data, possible risk of neurodevelopmental delay based on conflicting human data, so not as firm, but certainly possible. And in this case, in terms of carbamazepine, there is a caution for individuals of reproductive potential. So if you remember in the change in the pregnancy categories, from A through D and then X. The newer change also includes a category for not just pregnancy and lactation, but also for humans of reproductive potential, or IRP, as you see mentioned there. And this medications do have some labeling data associated with that. For lamotrigine or Lamictal, which I think, let's see, it was Joy that brought up the fact that she has a patient with bipolar disorder who is hoping to be able to use this medication during pregnancy. The caution, the label says caution advised during pregnancy, consider folic acid supplementation in the first trimester, possible risk of teratogenicity based on conflicting human data, risk of developmental delay not expected based on limited human data. So not a lot of information, but it was previously it's important to know that there are some risk associated with its use, and relatively speaking, so compared to some of the other mood stabilizers, it was previously considered a category C versus a category D. So if you had to use an anticonvulsant, then Lamictal is probably one of the safest choices. And again, I would emphasize that there are safer choices if the woman is able to tolerate them. For carbamazepine, we see increased risk of developmental delay, craniofacial defects, cardiovascular and urinary abnormalities, and fingernail hypoplasia or underdeveloped fingernails. That's what that means. For carbamazepine and valproate, we see neonatal effects such as hypoglycemia, hepatic dysfunction, and bleeding disorders. Less data is available for Lamictal, gabapentin, and topiramate with regards to neonatal effects, but that doesn't necessarily mean that they would not be present based on, similar mechanism of actions as the other two mood stabilizers. Specifically for valproate, you see the label there said weight risk versus benefits. It was previously a category D. Encourage the registry again. Also caution for individuals of reproductive potential is marked on the label. And again, if any of your patients are taking this medications, even for use of seizure disorders, I would still consider, and have a need to use them during pregnancy, I would still recommend the use of or participation in the registry as much as possible. With topiramate, risk of teratogenicity and low birth weight based on human data, possible risk of neonatal metabolic acidosis based on the drug's mechanism of action and transfer to fetus, and the risk of neurodevelopmental delays is inconclusive. But again, we do see an increased risk, and this was a letter to providers, letter to healthcare professionals, stating the risk of cleft lip and cleft palate is. Oh, sorry about that. Hopefully, we won't see any changes there. The potential for cleft lip and cleft palate may be increased for women, for babies of women who have taken topiramate during pregnancy. And again, just a reminder that these medications are used for other conditions than and not just psychiatric conditions. And along those lines, let's talk about their uses. So we know they're used for acute mania and agitation, maintenance treatment of bipolar disorder, sometimes not an FDA approved indication, but it's important to highlight that sometimes you might see these medications used for mood instability secondary to personality disorder. You might see them used for augmentation of antidepressant therapy, especially lithium and topiramate. Not to mention, of course, seizure disorders and migraine headache prophylaxis. Things like Lamictal can be are often seen in the, for more boutique, I would say, type of indications such as anger management, irritability, or impulse control disorders. And so, that is certainly an important consideration. Um, let's see. Is there something else I want to highlight about that? I'm just curious if I could get some answers in the chat about whether you've seen any patients that are in your current or previous caseloads that have taken these medications for mood instability associated with a personality disorder versus a bipolar 1 or bipolar 2 disorder. Okay, I see a few no's. That's good. It's actually quite positive. It's, of course, we don't have any FDA approved drugs that are helpful in the treatment of personality disorders. And so sometimes we reach to, what we can, especially when the situation is prompts it. But again, that would not be an FDA approved indication. All right, we're going to move on to talk about the antipsychotics. And for the sake of time and also efficiency, we're really only covering the second generation antipsychotics. There is very little to begin, I think, from discussion of the first generation antipsychotics because they're really not used that frequently anymore. And I apologize if you do work in settings where first generations are used routinely. Things like Haldol or Halcion or any of the other again, first generations or neuroleptics. Then there is definitely information out there, but again, it's not so much relevant to us at this time. For Risperdal, by the way, most of these medications were previously categorized as category C. There are more specific labels for each of those drugs. And so if you are curious about one specific drug that your patient may be taking, it's important for you to just, look at Hippocrates, look at the drug insert or information to gain more specifics. With risperidone, we see caution advised in the third trimester. Not a known teratogenic agent, but it is possible that because of the mechanism of action of the drug and exposure on the baby, you could see neonatal EPS or extrapyramidal and withdrawal symptoms. And in case you're wondering what it says, based on no known risk of teratogenicity based on animal data at 0.4 to 6 times maximum recommended human dose is what that abbreviation stands for. Though there's possible risk of fetal death at 1.5 of the maximum recommended human dose. So it doesn't, there are risks involved for sure. It appears that the risk of miscarriage is maybe higher than the risk of congenital malformations. But again, overall, this category of medications is considered, quote unquote, relatively safe. More evidence. We have more evidence regarding the typical than the atypical, simply because of the amount of time that they've been used. However, regarding the safety of antipsychotic medication during pregnancy, the data is still limited, but that data which is available suggests low risk. And again, in general, consider safer than the mood stabilizers. In one study, no neurobehavioral sequela was observed in the long term, with the long-term follow-up defined as 5 years. Clozapine, so Clozaril, has been associated with risk of increased gestational diabetes, and you would expect to see the same thing with Risperdal, Ziprasidone, or Zyprexa, and certainly with olanzapine. Ziprasidone is used on olanzapine or Zyprexa and risperidone are, as you know, highly associated with metabolic syndrome, and therefore you would expect that the potential risk of gestational diabetes would be higher for moms who need to take these medications. You could see floppy infant syndrome, seizures, and gastroesophageal reflux or GERD percent for the babies of moms who have taken clozapine during pregnancy. And it is possible, given that it is possible for the mom to develop a granulocytosis, it's also possible for the baby to develop a granulocytosis. Let's see, you see the labeling in front of you associated with the risk of gestational diabetes. Monitoring glucose is recommended. And yeah, that's pretty much all I want to highlight with olanzapine, quetiapine, and risperidone are not necessarily associated with increase in congenital abnormalities or anomalies, reduced gestation or birth weight. But again, you would assume, and it's safe to assume that based on the mechanism of action of this medication, that they do increase the risk of gestational diabetes. For quetiapine, again, risk is higher in the third trimester. Withdrawal EPS, neonatal EPS, and withdrawal symptoms is something to watch out for. And ideally, if you had to use this medications, any of these medications during pregnancy, you would want to taper to the lowest level possible during the third trimester, including potential discontinuation before the baby is born. But if discontinuation is not possible, then again, the lowest level possible is what I would recommend. For olanzapine, again, gestational diabetes I mentioned before. And everything else you've heard before, so I won't dwell too much on that. Latuda, one of you brought up Latuda before, and it is considered to be a relatively safe medication or safer medication for pregnant women. The Latuda's FDA formulation or FDA approval is for the treatment of depression during associated with bipolar disorder. So bear in mind that it's considered to be, even though it's in the class of antipsychotics, it is FDA approved for the treatment of depressive symptoms associated with bipolar disorder, as opposed to treatment of the manic symptoms. I haven't used it enough to be frank with you to be able to tell you whether it could help to alleviate some of the manic symptoms in some cases, but I have used it with at least one woman with bipolar disorder whose most frequent presentation was depressed, and she was able to both tolerate it and deliver without any baby risk to the baby or impact on the baby. This did require close coordination with her OBGYN, and again, monitoring closely throughout her pregnancy to make sure that she was only taken as little as needed throughout, and that was her choice. Let's see. Okay, aripiprazole or Abilify during the last 3 months of pregnancy may cause problems in the newborn, such as, again, some of the things that we've seen before, withdrawal symptoms, and potentially breathing problems, feeding problems, fussiness, or distress, tremors, and limp or stiff muscles. And it's definitely contraindicated during lactation. So, you know, one of the main takeaways here, hopefully, is that you should not recommend or advise a woman to continue Abilify if she is lactating. Um, okay. I think that's all I want to say about that. With ziprasidone or Geodon, there's very little data available for pregnancy or lactation, although again, based on the mechanism of action of the medication, you would expect to see similar risk compared to other antipsychotics. Okay, so it is important to highlight that women on atypicals have been found to have an increased risk of neural tube defects. So just like with the mood stabilizers, you would certainly be within your right, and it would be appropriate to counsel women on supplementation with folic acid and making sure that they are aware of the potential risk and in considering the possibility of decreasing or even discontinuing the medication use if at all possible during pregnancy. With the phenothiazine, so some of the older medications are actually used during pregnancy very commonly. If you know, for example, promethazine is used to treat pregnancy-related emesis or vomiting, nausea. If used throughout the pregnancy, the risks to the baby may include increased muscle tone or rigidity, and increased tendon reflexes. And this risk may persist over several months. So this would be a good time to maybe implement some behavioral changes that could help the woman deal with pregnancy-related emesis or, again, nausea and vomiting, otherwise known as morning sickness, which for some women is really old age sickness, and may last throughout the pregnancy. Diphenhydramine, so other medications, has been used to treat EPS and syndrome. Diphenhydramine is Benadryl, as you know, and it's used to counteract the anticholinergic effects of some of the antipsychotic medications. We do see higher rate of oral clefts in children exposed to diphenhydramine routinely, although diphenhydramine is was also previously considered a category B, which is among the safest of medications to use during pregnancy, and often given to women for the treatment of insomnia associated with pregnancy, or or of idiopathic nature. Um, May see a neonatal withdrawal syndrome, including tremulousness and diarrhea. And again, lowest dose possible is what I would recommend. Uh, Caution with the use of anticholinergics in that they can cause intestinal obstruction in the neonate and may also affect GI and motility in the mom. And as you can imagine, again, just thinking about the anticholinergic effect of drugs, consider the fact that children's or the infant's organs and metabolic processes are underdeveloped compared to the mom. So anything that could cause decreased GI motility for the mom or potential constipation may actually cause obstruction in the baby, which could be quite severe. In utero, exposure may produce neonatal jaundice. We talked about intestinal obstruction with some of the antipsychotics. In some animal studies, we see that prenatal exposure to the antipsychotics can cause persistent abnormalities in memory and learning, but there's conflicting results in this area, and overall, once again, I would advise to weigh the benefits versus the risk, and we've already talked about the last bullet there, and 2010, there was a prescribed label change from the FDA with regards to EPS and withdrawal syndromes in the neonates. So as you could see in front of you, this covers the entire class of antipsychotics, at least all of the ones that were in the market in 2010, including first generation antipsychotics. You could see things like Nabane and let's see, some of the older ones here, Haldol, et cetera, as well as some of the newer ones, including things like Invega, Clozaril, Fanapt, Geodon, et cetera, et cetera. So every class of medication, every every drug in this class of medications received this label change. And so as a whole, it is, again, it's important to note that children of women who've been treating with antipsychotics, especially in the third trimester, can experience extrapyramidal symptoms and withdrawal symptoms after delivery. Okay, time for other questions. So let's go ahead and test your learning now with questions 10 and 11. All right, we're going to go ahead and end the poll. Thank you, everybody, for answering. Some of you have seen 11 already, so hold that thought. For now, let's focus on question number 10. And question number 10 said, gender refers to the biological categories of male and female. This is just a question from the material that we covered yesterday, just trying to make sure that you're not forgetting some of the things we've already talked about. And the real answer, which 57% of you agreed to, not counting the people in the chat box, answering in the chat box, is false. So sex refers to the biological categories of male and female. And if you recall, gender refers to psychosocial constructs of what it means to be a man or a woman in a specific society. So good job, and just bear in mind again, sex, biological categories, male and female, usually categories assigned at birth based on external characteristics. Gender is much more complicated than that. Oh, I don't think I shared the results. Sorry, I was reading without sharing, and I apologize for that. So here are the results of poll number 10. And now let's go ahead and post the question number 11, which some of you have answered. All right, let's go ahead and end the poll with 83% of you haven't responded, and share the results. The correct answer is actually all of the above, and that's just based on the question itself. You are absolutely right that the most common site for women most women common type of cancer in women is breast cancer. However, in order, breast, lung and bronchus, colon and rectal, uterine corpus, and thyroid cancers are the most common sites of cancer for women in the US. So in this case, the answer would have been all of the above. I think we did have some people both in the chat and also in the poll that were able to pick up on that answer. And I don't mean to be tricky, but I would recommend, because a lot of the questions that are going to be both in the exam and in the PEP and your comprehensive exams are about the incorporating the material. Just, be very mindful of what the question is pulling for. There may be more than, what I'm trying to say is there may be more than one right answer, and what you want to pick out is what is the best answer in this case. Okay, let me go back because I've lost my place already. Okay, we're back to slide number 181. Let me just, okay, stop sharing the poll. And here we go. All right, so slide number 182, we're going to start talking about the benzodiazepines. In general, most were considered category D, and there are very few indications for the use of benzodiazepines during pregnancy. However, one thing that I want to make sure to highlight is that you don't want to abruptly discontinue a woman who's been using benzodiazepines, and especially if they have been using those benzodiazepines for a significant period of time. What would be the risk of abrupt discontinuation? If you can share with me on the chat, what would you be concerned about? Angela says seizures. Exactly, Maribel agrees. That's exactly right. So withdrawal syndrome, which may include seizures and could be potentially fatal, could be the risk of abruptly discontinuing the use of benzodiazepines in pregnancy. So again, whenever possible, if you have a woman who is taking benzodiazepines and is planning to conceive, you want to start a tapering schedule that is appropriate and timely before they get pregnant. And if you happen to have a pregnant patient who is currently taking benzodiazepines, then once again, you would not want to abruptly discontinue, but engage in a very appropriate and slow taper. Angela asked, what would that schedule look like? In general, there are different methods of discontinuation, and it depends on whether you're talking about a short-acting versus a long-acting benzodiazepine. But a general rule would be reducing the dosage by 25% every couple of weeks. So really you're looking at potentially, let's see, what math in public, that would be 8 to 12 weeks in general before you are able to completely discontinue the use of the benzodiazepines. And again, that depends on whether, the length of time that the person has been using, whether they're using a shorter acting versus a long acting. So more to come on that, but normally you would be looking at 20 to 25% reduction in dose every couple of weeks. So with clonazepam, again, no known risk of teratogenicity, although we've already mentioned that all the benzodiazepines are considered or are thought to be suspected teratogens. We do have risk of infant floppy syndrome near term based on some human data, risk of withdrawal syndrome in the neonate, which again could potentially include the risk of seizures. And so they would be definitely contraindicated. Temazepam, I want to highlight because it was one of the few psychotropics that was considered a category X, meaning no really good reason to use in pregnancy. If, in general, unless it was life-saving, it would not be a medication that we would want to use in pregnancy. So definitely consider alternatives. There's risk of teratogenicity, withdrawals, risk of withdrawals, and floppy hindrance syndromes as well. Some of the risk that you might see with these and other, and I'm giving you a couple of examples, but in general, with the benzodiazepines, you might see a risk of cleft palate, and some, although it's pretty unclear, approximately 1% in some studies, and you might argue that that might be the base rate risk for cleft palate, so it's hard to determine. Definitely risk of floppy infant syndrome, which I've already talked about, and just for a definition, that involves hypotonia or low muscle tone, respiratory depression and hypothermia, or low body temperature, especially when used close to birth. And this risk appeared to be dose related. So there again, you definitely want to, if you had to use, you'd want to keep it at the lowest dose possible. Let's see. They can be associated with hyperbilirubinemia in the newborn, withdrawal syndrome with prolonged use. If used, the recommendation from this book, I'm not sure if you can see it in the camera, but that is one of the books in your syllabus and in your reference material, is called Psychotropic Drugs and Women, Fast Facts. This edition is 2004, I want to say. So it's not the latest and greatest, but the reality is that there hasn't really been that much in development in terms of psychotropic medication in the, for at least, I would say for at least 5 to 10 years, there was very little in terms of development of new psychotropic medications. And then there were some. So lately we've seen more newer antipsychotic, antidepressant, and other medications in the market, mostly of those two types. But this is a pretty good guide. So according to the Psychotropic Drugs and Women Fast Facts, if you use the shorter acting agents, the ones that don't have active metabolites, such as lorazepam, those are considered to be safer. Relatively, of course, this is relative safety, not complete safety. So no matter what agent, once again, you want to avoid discontinuation. So I just want to open to one of the things. So what you'd want to avoid longer acting, let's see. Yeah, some of the reasons you'd want to avoid the longer acting benzodiazepines is the potential for accumulation in the infant, and who, of course, as I mentioned already several times, cannot process the medications with the same efficiency or speed as the grown adult. So in the case of benzodiazepines, this accumulation may present as sedation, depressed respiration rate, lethargy, and that floppy infant syndrome that I talked about. Shorter acting benzodiazepines do have a higher risk of withdrawal and of course have a higher potential for abuse in the mom. So if we're talking about things like lorazepam and alprazolam or Xanax, the abuse potential as well as the risk of withdrawal is higher. So in both of them increase with prolonged use. So the best way to avoid withdrawal, as I mentioned before, is to provide that slow taper ideally tapering mom off prior to term in order to reduce the risk of withdrawal in the baby. Okay, I think that's all I want to say about that. Oh, sorry, that was in my slides and I didn't realize that. Okay, yeah, I think we've covered most of that, so don't need to go over that again. Okay. So in general, once again, their advice is shorter acting agents and agents without active metabolites like lorazepam may be a reasonable choice, quote unquote, although the dosage and the length of use should be minimized. And no matter what the benzodiazepine may have been used, taper slowly before delivery, ideally. Also consider discontinuing or reducing the dose significantly while nursing, although on the whole, shorter acting agents without metabolites like the lorazepam and oxazepam could be safer alternatives during nursing because they reduce sedation in the baby. It's important to note that the anxiolytics readily cross the placenta and can accumulate in the fetus after prolonged administration. They have been found in fetal brain, lungs, and heart. Metabolism in general, you know, the finding here is specifically for diazepam or Valium, but I think it could be assumed to be the same for most of the other drugs, if not all. That the metabolism is going to be slower than in the fetus than in the adult, with the half-life potentially extending as much as twice as long, or several times as long as they would be for the mom. Okay, and you can see for yourself the other notes with regards to increased risk of oral cleft. But it's still considered low risk. There's something called a benzodiazepine exposure syndrome that you want to be aware of, and that includes signs, symptoms such as growth retardation, dysmorphism, which is basically an anatomical malformation, or an abnormality in the development of some or form of some organ or structure, and mental and psychomotor retardation in infants. And the benzodiazepines have been associated in case reports of Epstein's anomaly, which we talked about before, as well as neonatal lethargy, hypothermia, hypotonia, and withdrawal. Which, just a reminder what Epstein's anomaly looks like before. So once again, if you want to, you know, kind of take a shortcut with regards to studying for the test, remember the association between the Epstein's and lithium, as well as benzodiazepines. Okay. And as we know, the anxiolytics are used to treat acute anxiety, panic disorder, agitation, insomnia, and akathisia secondary to initiation of SSRI treatment. I'm not sure if, and I would be curious to see if you've seen that as a use presently, but I used to, I think more so before I became a prescriber than since, but I used to see PCMs routinely offer a short-term prescription of clonazepam when they started folks on the SSRIs as a way to counteract potentially some of that akathisia or agitation that may come with the prescription of SSRIs. I think out of a belief that it could decrease suicide risk associated with new treatment with SSRIs. I haven't seen it as much lately, but it's certainly it was certainly in use in some settings that I can think of. And certainly these medications are used for alcohol withdrawal, as well as other psychiatric and medical uses. Things like periodic leg movements are often treated with clonazepam and other longer-acting benzodiazepines, seizures and status epilepticus, preoperative sedation, and muscle spasms are also treated with benzodiazepines. All right, I think we are going to move to the category, to another drug category, that of the sedative and hypnotics. And I'll tell you right now, I don't have data on all the sedative hypnotics. There's more, there seem to be more coming on the market than sometimes we can keep track of. And certainly, again, I don't have a lot of experience working with those sedatives because of the limitations of our formulary. But in general, we considered this class of medications to be reasonable to use within certain limitations in pregnant women. So the Z drugs, zolpidem and zopiclone, are were previously categorized as C drugs, but now the recommendation is to consider alternatives, and some of those alternatives could be diphenhydramine or Benadryl. There's a possible risk of fetal toxicity and death based on the animal data, possible risk of neonatal respiratory depression and withdrawal symptoms, especially when administered near term. But in all, we have limited data available. You would expect that based on the drug's mechanism of action, you might see withdrawal symptoms and CNS depression, or heightened lethargy, or drowsiness because of accumulation in the neonate or the newborn. As far as lactation, we want to likely avoid due to limited safety data. Observe the infant for sedation if used, and I would certainly recommend heightened consideration for whether or not you really want to prescribe a sedative hypnotic to a nursing mom. As you know, changes in sleep patterns, including decreased sleep, are both typical and also necessary for new parents, because children are often on feeding schedules that are much more frequent than a typical period of sleep of 8 hours. And so if you're going to offer a sedative to a mom, she might oversleep, she might not hear the baby, she might not respond to the baby, and put her baby in peril, perhaps, because of use of sedatives. In I think extreme circumstances with a very supportive partner, and making sure that appropriate safety precautions have been taken, I have prescribed a sedative to the mom, again with the understanding that dad or the other the other parent, the other partner, is responsible for nighttime feedings, that mom is able to provide an alternative, such as pumping or the bottle formula, that is, so that baby is not going to go unattended for again a long stretch of time without feedings. So it's really important to keep that in mind. Per FDA, as far as the lactation is concerned, they are considered possibly unsafe, and would want to make sure that we consider alternatives. And again, I would recommend safety precautions when it comes to sedation, using sedatives with nursing moms. Okay. As far as the psychostimulants, we'll talk about all of them as a class. Together, if we look at methylphenidate and all its formulations, we have Ritalin, Ritalin LA, Concerta. They all were previously, most of them were previously considered category C. Now, most of them are labeled with a caution advice. With Adderall, it actually explicitly has a contraindication. It says to avoid use during pregnancy. There's human data that describes the risk of teratogenicity, and there's risk of complications in the baby upon delivery, including low birth weight. And of course, there's risk of dependence, the risk of tolerance. With Focalin or dexmethylphenidate, questionable risk of neonate withdrawal, and yet, caution advised, inadequate human data is available. As far as lactation is concerned, we recommend caution advised, no human data is available. Possible decreased milk production based on decreased prolactin levels, and this would apply specifically to Focalin, but I think the same could be assumed of other forms of methylphenidate and potentially Adderall. I want to share with you just, and this may be my bias, I totally own it, but I think it's important to consider risk for the mom and risk for the baby associated with the medication use, as well as the lack of medication use and potentially alternative treatments. We just recently had a consult from a mom who was from the labor and delivery unit about a mom who was 2 days postpartum and still in the hospital. And the consult was whether or not it was appropriate to restart her Adderall because she was forgetting to feed her baby. And so again, I totally own up to my bias, but in my way of thinking, if the attention deficit is so significant that 2 days postpartum, when multiple things are going on, including potentially postpartum blues, tiredness or fatigue from the labor and delivery, and presence or lack of support from the partner, it seemed to me a little bit premature to think about using ADHD medications or psychostimulants medication for the mom to remember to feed the baby. Babies pretty much remind you to feed them. And so if that's a consideration, then, I think from a biopsychosocial perspective, something else may be going on. So just remember, when you educate your patients about the use of these medications during pregnancy or lactation, to consider both their social situation and the resources they have available to them before making a recommendation. Okay, I think we just have a couple of slides. Actually, yeah. Yeah, I'm going to finish the section on psychostimulants, and then we're going to take another break shortly. Okay, so with regards to other formulations such as Vyvanse, once again, avoid use during pregnancy. There's not enough data available, but there's some limited, there's enough data that would suggest teratogenicity with the amphetamines, as well as complications for the newborn. Avoid use while breastfeeding if potential abuse, otherwise caution advised. There are no known risks to the infants with appropriate use, but there is a possibility of drug excretion into the milk. So again, consider weigh the risk versus the benefits. I am aware that modafinil and Nuvigil are not, or armodafinil or Provigil and Nuvigil are not necessarily psychostimulants, but they are often used in lieu of, or also, in addition to treatment of circadian rhythm disorders and daytime fatigue. So that's why I've included them in this class. And both of them recommend consideration for or avoiding use during pregnancy. Risk of embryo fetal toxicity based on animal data at less than the recommended human dose has been reported. So modafinil and armodafinil would be a relative contraindication during pregnancy. Okay. And then atomoxetine or Strattera, not necessarily a psychostimulant with regards to, the mechanism of action, but certainly primarily used for the treatment of ADHD or attention deficit these days. The label speaks to caution, especially in poor CYP2D6 metabolizers. There's inadequate human data available to assess the risk, and lactation safety unknown. So caution advised in this case. This drug was previously classified as a category C. So again, caution advised does not necessarily mean contraindicated. You would want to weigh the risk versus the benefits and advise the mom appropriately. So obviously we know that this type of medications are used to treat conditions such as attention deficit disorder, but they're also used to treat acquired cognitive dysfunction from traumatic brain injury and other cognitive or neurocognitive problems. Strattera is often used to treat anxiety. Provigil and Nuvigil used to treat narcolepsy, as I mentioned, and other circadian rhythm disorders. They could be used for the treatment of depression in the elderly. Of course, pregnancy and lactation would not be consideration in that regard. But they can also be used as augmentation of antidepressant therapy. So this would be an area where potentially we might see about discontinuing the psychostimulant and potentially continuing the mom on the antidepressant therapy alone, if possible. All right. With that, let's go ahead and stop for a 10-minute break. I have my time is 14:01, yours is 11:01 if you're in the Pacific. So let's come back 11 minutes after the hour. It's late. Oops, and I just realized my computer may need a little bit of charging, so bear with me one moment. Okay, we should be good to go. All right. Okay, excellent. Thank you all. I will say, just want to start the next section by saying we're gonna wrap up the pregnancy slides and move on to lactation, very likely within the next hour. Also, I think we have one or two poll questions, possibly one that we'll go through. And I am likely to give you a case study for thoughtful discussion over lunch as well. So not to discuss over lunch, but to think about questions and thoughts for discussion over lunch. And Aiden, whenever you like, you can go ahead and post the attendance. You can stop me at any time. Okay. Thank you. Keep getting this notice that my internet connection is unstable. Okay, let me go ahead and let's go ahead and do the attendance now. All right, are we good?
I'm gonna close the attendance in just a few seconds.
Sure. All right, excellent. Let's move on to talk about other drug types. So this is a little bit of a catch-all for, regarding all the classes, different classes of medications that we haven't talked about yet, including Campro, which some of you may have heard of using or have seen used before for the treatment of cravings, alcohol cravings associated with alcohol use disorder. There was a safety labeling change with regards to Campro, with risk of carcinogenicity, mutagenicity, and impairment of fertility. So this would not be just an advisement for pregnant individuals, but potentially for all individuals of reproductive capacity. Now, bear in mind that this finding has to do with animal studies at doses 5 times the maximum recommended human dose. Um, uh, wait, 60 days animal studies, and in females taking 5 times the recommended human dose, they didn't seem to find any effects on fertility. That being said, there was an FDA warning, and so that's something that your patients should be educated about. So as we wrap up our conversation about psychotropic use during pregnancy, again, I want to remind you of the fact that there are no double-blind placebo-controlled studies involving pregnant women. Therefore, any information that we have, as I mentioned before, comes out of post-marketing studies and case reports, and that information which is available in the birth registries that we need to be able to advise our patients about. In general, the older the medication, the more information that we have. That doesn't necessarily mean the older generation, the safer, medication. Remember that coming out of the gate as a brand new drug before 2015, they could have been categorized as a C drug, essentially saying there was not enough information available as to with regards to safety, or even potentially a B, but then changed to a D category, or even an X category based on post marketing studies. And Paxil is a good example of that. Medication that came out on the market as a C drug, and then was later categorized as a D drug. Nowadays, as you could see, a drug may be described as having, as a caution advised, no human data, but that is you should not imply that means the drug is relatively safe. Because, as I mentioned before, we just don't have enough information when the drugs are marketed. Also, it's important to, also understand that all psychotropic medications are assumed to cross a placental barrier. The reason they work on the brain is because they can cross the blood-brain barrier, and the placental barrier is similar. So it would be safe to assume that if it's affecting the mom in the way that it's intended to, then it's likely having an effect on the baby. Placental transport does vary depending on several factors, including the molecular weight of the drug, the protein binding effects of the drug, the polarity and lipophilicity, or a tendency to be fat soluble, or like fat substances, and the duration of exposure. So again, all in all, don't assume that drugs are safe. You can make an assumption that, or make an informed decision that a drug is relatively safe based on, information that I have provided, as well as the drug inserts and the article that I share with you. And that's the information that should be passed on to patients. We're going to now move on to talk about breastfeeding. And I've already covered some lactation information with regards to some of the drug classes that we've discussed so far. But I think it's important to keep in mind that there are labeling indications or labeling rules that affect lactation separately from pregnancy. Okay, so some facts about breastfeeding, just so you know the magnitude of the, or how this may impact your individual patient that you may be advising. As of 2015, I haven't seen any later reports. There's a report called the CDC Breastfeeding Report Card, the Centers for Disease Control Breastfeeding Report Card, that says that 83% of women who gave birth breastfed their babies for at least a period of time. So, period of time obviously varies from child to child, woman to woman, but the rates of breastfeeding are steadily increasing and have been steadily increasing in the past several years. Normally at about 6 months, about 25% of women are still exclusively breastfeeding, meaning they're not supplementing with formula in terms of milk use. 57%, roughly 58% are breastfeeding some, and at 12 months, 36% are breastfeeding some. So again, quarter are breastfeeding exclusively at 6 months. More than half are breastfeeding to some extent. And at 1 year, about a third of women are still breastfeeding. It is difficult to interpret the association between how much of the drug actually enters the breast milk and its impact on the baby. And so there is not, obviously we can pump breast milk, we can measure the amount of drug that is present in the breast milk. But as far as whether those milk measurements translate numerically to risk or effect on the baby, it is much less clear that that's the case. And you see in front of you some factors that affect the drug concentration in the breastfed infants. In the mom, those factors include the milk composition and the pH, the mammary blood flow, and the maternal drug metabolism. So if you have a mom who is a slow metabolizer of the drug versus a mom who is a fast metabolizer, that's going to affect the drug concentration in the milk. We've already talked about some of the factors associated with the drug that could affect the concentration in the breast milk. But the ones that I want to highlight that we haven't talked about yet include the dose and the dosing interval, as well as whether the formulation is immediate versus sustained release. And in the infant, there's a lot of factors, and most of them boil down to the fact that the infant's organs are underdeveloped, and as such, you would expect a slower metabolism and, in general, pharmacokinetics effects, as well as, several other factors, including greater, the amount of milk consumed, the amount and timeliness, or, time intervals of the milk consumption, as well as things like an increased percentage of body water and extracellular fluid. That's what ECF stands for. Okay. And, as I mentioned, the neonate has some unique characteristics which may affect drug action, such as decreased hepatic enzymes. For example, glucuronidation, which, as you know, is another, metabolic process, or yeah, I don't know. I guess that would be the right way to say it, or yeah, drug processing system in the body, as well as oxidation, may be only 20% of adult levels. So obviously, a drug that is metabolized via oxidation or glucuronidation is going to be accumulated in the newborn. Okay. So in general, all this, translates into the baby having a greater amount of exposure to higher serum concentrations of the drugs compared to the mom. And this is something that we're going to cover in our next class, because I think it's important for you to understand how metabolizing status can affect the mom differently than the baby. So, in this case report, a woman or an infant death was thought to be related to breastfeeding for a mom who was taking codeine. If you recall from some of your other classes, codeine is a prodrug, meaning it requires the hepatic metabolism to activate it into the active agent, which is morphine. And in this case, specifically, the mother was determined to be a ultra rapid metabolizer. That's what stands for, of 2D6, meaning her conversion of the drug codeine to morphine happened more rapidly and completely than other people. So slow metabolizer or normal metabolizer, normal quote unquote, metabolizer would have converted the codeine to morphine at a much slower rate. So in this case, morphine, mom metabolizes codeine into morphine pretty rapidly and efficiently. In nursing, her baby was exposed to higher levels of morphine than would have been much more rapidly than would otherwise have been expected from a regular or slow metabolizer. And the baby actually died from this effect. Okay. There are certain drugs that are contraindicated during lactation, including some of the things that we've already talked about: amphetamines, cocaine, heroin, lithium, marijuana, nicotine. Some of those drugs of abuse likely would be contraindicated no matter what. But certainly it's important to be mindful of some other, some drugs like nicotine, marijuana, and amphetamines, which could potentially be commonly used depending on where you are and where you practice. Okay, we're going to talk about the antidepressants next. When it comes to lactation, antidepressants are present in breast milk at a milk serum ratio of greater than 1. That being said, once again, the milk serum ratio only tells you so much, because the effects on the baby are not necessarily going to be related to the numerical value of the drug that is present in the breast milk. In alcohol is not contraindicated. Not an absolute contraindication. Part of the reason is because of the way that alcohol is metabolized. So high amounts of alcohol would definitely be contraindicated. But it is possible that mom can engage in moderate drinking and time the consumption of alcohol to long periods of time where the baby is sleeping or not lactating, or use the pumping and dumping techniques, which we're going to talk about, to minimize the effect of alcohol on the baby. So alcohol is not a total contraindication, but certainly I would address, more than moderate levels of drinking for a nursing mom. Let's see, for TCAs, they enter the breast milk, but their metabolites are undetectable in the infant serum by 10 weeks. There's no evidence of accumulation in the neonate. The exception to this is doxepin. Again, not very frequently used, but you might see it in some settings, and it does show accumulation in respiratory depression. So doxepin would be contraindicated for lactating moms. Amitriptyline and desipramine reach a peak in breast milk at 4 to 6 hours after an oral dose. And why is this important? It's important because of what I said before. Some moms that had required taking these medications during while breastfeeding may choose to time the feedings of the baby or time the administration of the drug in order to minimize the impact on the baby. So in this case, a mom who is nursing may pump and dump a breast milk at about 4 to 6 hours after the oral dose, meaning she would pump her breast milk and dispose of it as opposed to giving it to the baby. As far as the milk and serum, percentage of the drug found in breast milk, you could see the different rates for amitriptyline versus clomipramine and some of the other TCAs. And again, just emphasizing avoid using doxepin because of the reported risk of dangerous sedation and respiratory depression and potentially poor sucking, which may lead to underfeeding. Okay. With the SSRIs, more common use and potentially good options, especially in the treatment of postpartum depression. The SSRIs may accumulate, especially those that have active metabolites like fluoxetine. Studies are controversial due to the methodology and also the small number of women that have been studied. Sertraline's peak concentration occurred at about 7 to 10 hours after maternal dose. So once again, by discarding one feeding at 7 to 8 hours after the maternal dose, the infant's daily exposure could be decreased by 25%, which may not seem a great deal, but it's certainly a safer or a better recommendation than not at all. Relative infant doses, for the SSRIs are listed there. Again, I would caution that they don't necessarily mean much of anything. If you were asked for advice with regards to, let me pull it up to make sure that I'm giving you the right information. Often consultation or a common consultation from the labor and delivery folks or from OBGYN, although they should know this. And with regards to postpartum depression, treatment of postpartum depression, sertraline is considered to be the SSRI of choice for breastfeeding moms. You'd still want to use the lower dose available, lowest dose that could be effective, and try to keep it at the lowest level possible for lactating moms. And again, keep in mind discarding one feeding, discarding one pump may actually decrease the exposure to the baby. Celexa is not ideal. So I would consider a switch to Zoloft, and the same could be said of Prozac, Paxil, and Luvox, if that's what the mom had taken before pregnancy or before delivery. Again, want to emphasize sertraline is the SSRI of choice for lactating moms. Let's see, MAOIs, phenolzine and tranylcypromine, no reports of use during lactation. Extreme caution, we just don't have information And again, same contraindications as with use during any other time with regards to dietary restrictions, and with regards to potential hypotensive crisis. And so likely avoid if at all possible. Um, Relative infant doses of venlafaxine and mirtazapine were higher than some of the SSRIs, and in general, they're not considered drugs, first choice drugs when it comes to treating postpartum depression. As far as the antipsychotics, they are excreted into the breast milk, but the milk serum ratio is actually less than 1. Some excretion occurs with all the antipsychotic medications. However, data to date suggests that levels are pretty low, and levels that are, as low as less than 3% of the maternal dose. You obviously, like I've advised in other situations, want to be wary of newer agents compared with others for which we have more data. Just, kind of goes without saying. They're not necessarily contraindicated during breastfeeding as a class. And again, the magnitude of the problem of major depressive disorder with postpartum onset, especially if it presents with psychotic symptoms, is such that you could truly see this as life-saving medications, both for the mom and for the baby, if that diagnosis was present. Anxiolytics are considered to be relatively safe in low doses. Is not or rather, relatively low doses of anxiolytic use are not necessarily considered a contraindication to nursing, which is curious compared to what I told you before about use during pregnancy. Benzodiazepines appear to have lower milk to maternal serum ratios than the other psychotropics. So short-term use, especially with the shorter acting psychotropics, may be safe. In general, consider moderately safe. And as I mentioned before, the shorter acting agents may be preferred. But there is risk of accumulation with longer acting agents and prolonged use. So again, short-term use if needed, although we do have some alternatives. And I suppose if the alternative in terms of, for example, treating a generalized anxiety disorder, OCD, or a panic disorder, is potentially using sertraline as opposed to using benzodiazepines. Mood stabilizers are present in the breast milk. Lithium is considered to be potentially hazardous, as breast milk levels are 30 to 50% of maternal serum level. And as you know, the baby cannot process those level of serum concentrations. Really need to monitor the baby closely for hydration status with lithium if it needs to be used. I've never had a breastfeeding mom on lithium, so and lithium is less and less used these days, so that's not necessarily that unusual. Carbamazepine and valproic acid are present in low concentrations, and they are considered to be compatible with breastfeeding. So once again, this is somewhat different from the information that you receive with regards to use during pregnancy, and it highlights the need for having safety labeling that addresses pregnancy separate from breastfeeding and separate from use with individuals of reproductive age or potential. So they are considered probably safe for use in breastfeeding. Low risk for carbamazepine, other than a slight concern regarding neonatal jaundice. Valproate, generally considered low risk, relatively low infant dose compared to the mom's dose. But you do want to avoid potentially hepatotoxic drugs like acetaminophen because of the activation of liver enzymes and also because of the underdeveloped hepatic metabolism of
It's not on Netflix.
the
right?
babies. I'm sorry, is there a question? Okay, got it. All right, for lamotrigine, we do consider lamotrigine unsafe. So going back to, the case that Joy had presented, pregnancy versus lactation have to be considered separately for this agent and pretty much all the others. Available data demonstrates high risk of significant adverse effects to infant and breast milk production. Medication is contraindicated or requires cessation of breastfeeding. So I suppose if a mom required the use of lamotrigine in the postpartum period because of seizures or because that is the only medication that could control their symptoms of bipolar mania, then the best advice would be to advise cessation of breastfeeding. All right, with that, let's discuss our next poll question, number 12. All right. We're going to go ahead and close the poll with 76% of you responding, and I'll go ahead and share the results. The question is, anxiolytic use at relatively low doses is not considered a contraindication to nursing. Benzodiazepines appear to have lower milk to maternal serum ratios than other psychotropics. And most of you, 60%, chose the correct answer, which is true. If you go back to slide number 211, that is exactly what it says. In general, benzodiazepines are at relatively low doses and for a prescribed or limited period of time are not necessarily contraindicated for nursing. So good job. I make sure everybody's staying involved and paying attention. So thank you for responding. All right. So now what? I've given you a lot of information about the risk associated with use of medications during pregnancy and during lactation. And at this point in the class, some of you, maybe all of you, are wondering, what do I do? I mean, it seems like, again, the ideal is for women not to be taking psychotropic medication, not to expose themselves or their babies to the use of psychotropic medications. There's a lot of nasty and difficult side effects that and potential lifelong that could potentially have lifelong consequences to address. And although the risk of things like pulmonary hypertension or neural tube defects, maybe 1 in 3,000, or anywhere from 1 in 10,000. If you happen to be that one, if your patient happens to be that one mom with that one child, again, this could potentially have very significant consequences. So I don't mean to scare you. I just want you to think about, how think about your own views and the knowledge that you have been given, and how you want to think about addressing those issues for yourself and in your practice. So in general, these are some considerations that you may wish to have. The risk of morbidity, the morbidity and mortality of untreated mental illness during pregnancy and lactation is no joke. It's not fully evaluated. I don't think we have, enough research to suggest one way or the other. Why? Because women with untreated mental illness may not be seeking medical prenatal care, much less especially mental health care. And so we don't necessarily have enough information to assess the risk of untreated mental illness versus the risk of treating these conditions with psychotropic medications. We do know that some conditions may improve during pregnancy, including panic disorder. Others may worsen. OCD symptoms tend to increase during pregnancy and in the postpartum. OCD type symptoms may also be present for the first time in the postpartum period, and you'd find many moms who don't necessarily meet criteria for OCD or even an anxiety disorder who have intrusive thoughts about harm befalling their newborn, their children. And so that is something that of course can develop into an anxiety disorder. Psychotic disorders like schizophrenia and some of the others listed there can worsen during pregnancy and generally do. And rates and severity of depression vary widely depending on the methodology of the assessment. You can assume that assessments that include a lot of biological or medical physical symptoms of depression may represent an exaggerated number of depressed moms because of the physical and medical discomfort and complications associated with pregnancy, such as insomnia. But symptoms or assessments that focus on emotional symptoms and may also present an exaggerated picture of depression during pregnancy because of the mood lability associated with the hormonal changes that happen during pregnancy. And so it is tricky, it's really tricky to know whether we're seeing more or less depression during pregnancy based on those assessments. We certainly do know that the increased stress during pregnancy can increase maternal serum concentrations of cortisol, which can be detrimental to infant brain development. I think you've learned in other classes about cortisol and effects on neurochemistry and neural pathways. And we just don't know, how much is how much is too much when it comes to exposing a developing organism to high levels of cortisol, and what effects that could have potentially in psychological and cognitive and developmental problems that may present in later for the child. Many pregnant women can experience the new onset or recurrent or worsening symptoms of pre-existing psychiatric disorders. And, one of the cases that we discussed was of a woman who's been stable and asymptomatic for 2 or 3 years before deciding to get pregnant. And yet, how do we know that pregnancy, and again, the hormonal and physical and social changes associated with it are not going to bring on, a recurrence of her previously existing mood disorder. We do see a high percentage of relapse in women with major depression who discontinue or change the medication during pregnancy. And I've seen it myself. I've been, taking the most conservative approach with patients and discontinuing their medication in the first trimester as soon as they found out that they were pregnant, only to see their mood decompensate and their functioning starting to wear off to the extent that they had trouble, having positive feelings about the pregnancy, positive feelings about the baby, and even planning for the postpartum period because of their distress. And so, and what do you do in those situations? Well, you think about reintroducing the drug at the lowest level possible, especially in the second trimester, if it can be done, and then potentially discontinuing again in the third trimester, but also, likely having to keep the medication on if you need it, and or considering how you're going to handle postpartum depression if it presents itself. Of patients who relapse, 50% do so in the first trimester, 90% by the end of the second trimester. So clearly, we have to assess not just periodically, but continuously a woman who is pregnant and who's had a history of mood disorders or other mental health conditions, and take it potentially day by day, week by week, and making those risk versus benefit determinations could change entirely. I have had patients who were vehemently opposed to taking medications during pregnancy, who ultimately ended up accepting the need for those medications based on how their mood and other problems started to decline. Again, I mentioned the fact that most women are not aware of their pregnancy until at least 6 weeks, which falls right in the middle of the critical period of development. And so, can we actually avoid exposure of the baby in the first trimester? And the answer is no, not likely. 50% of pregnancies are unplanned, as we talked about. And the abrupt discontinuation of psychotropic medications may result in relapse or withdrawal symptoms. And, and again, we have to consider the risk for the mom and for the baby if that were to happen. One thing that I would say with regards to the fact that most women are not aware of their pregnancy until they've already, potentially have been exposed and have exposed their babies to multiple agents, not just psychotropic medications, is that as soon as possible, one recommendation is that as soon as possible after you find out a patient of yours is pregnant, it's important to try to do a real-time account of any things that they may have been exposed to. So my first visit with a woman who's just found out that she's pregnant will entail looking back at the last several weeks, potentially a couple of months, to see if they've taken any over-the-counter medications, if they've used any nutritional supplements, including workout or pre-workout substances, if they've been exposed to any environmental toxins, for example, my moms who work in the aircraft maintenance, or, who have to deal with fuels or chemicals. and documenting that to the best of your ability, because both for the mom and for your own liability, you want to make sure that those things are taken into account in real time. Because 9 months, 9 months from now, or 7.5 months from now, when the mom delivers a healthy baby, none of that will matter. But if the mom delivers a baby who has any kind of complications, she's not going to remember, what she was exposed to at the beginning of her pregnancy, as well as she could, just 4 to 6 weeks into it, if that makes sense. All right, I know we're getting awfully close to lunchtime, but I think, yeah. Well, let me go ahead and stop here. We're on slide 220, or 219 actually is the one that we just covered. I want to go over another case after we come back from lunch. So I'm going to go ahead and tell you a little bit about the case now. And once again, I want you to think about questions, recommendations. Now that you've gotten my entire spiel about potential risk of medication use, as well as, risk of untreated mental illness, mostly what I want to focus your attention on is what recommendations, what therapies, what interventions you may suggest for this mom who I'm going to talk about right now. Okay, so mom is a 24-year-old African-American with history of one episode of depression associated with a significant life transition. In her case, it was a move away from home, her family and her fiance. Career dissatisfaction, stressful work environment. She was previously pretty anhedonic, meaning low pleasure, low desire to engage in pleasurable activities, and had responded well to citalopram 20 milligrams and a course of therapy, which included behavioral activation and cognitive restructuring. She was recently engaged and pregnant for the first time. This is not the this is not, this is definitely a wanted pregnancy. She was very happy at first, and now when she came in to see me, she is in her second trimester and reports she does not feel a connection to the baby, does not care to find out about the gender, does not talk to the baby, feels physically uncomfortable and pained, does not sleep well due to physical pain from a previous motor vehicle accident, as well as her growing belly, has no appetite, no social support, and is unwilling to ask for help from others. Bear in mind that the fiance, the father of the baby, is geographically separated from her, and she had opted initially to discontinue antidepressant therapy in the first trimester. So this is her at about 20 weeks. Let's see. Significant apathy, was again initially happy with the pregnancy, and now feels that her feelings have changed, and she feels disconnected with the baby, has trouble talking to it, or even thinking about preparation for birth, thinking or talking about names. Also complains about insomnia and, as I mentioned before, decreased appetite. By her report, she's eating a diet of rice and chicken once a day, and otherwise just grazing throughout the day. And is currently reporting weight loss, which is inappropriate for the development of the baby. So once again, we're talking about a 24-year-old African-American female with history of one episode of depression prior to the current pregnancy, that responded well to Celexa 20 milligrams and cognitive behavioral therapy. This is her first pregnancy, and I've already shared with you some of her presenting problems, including insomnia, anhedonia, low appetite, feeling disconnected from the baby, no social support, and pain and discomfort. Okay, so again, the key here is to think about potential recommendations, biopsychosocial, therapeutic, and pharmacotherapeutic or otherwise that you might make for this month. And with that in mind, we're going to go ahead and break for lunch. Thank you all for your participation this morning, and I look forward to your thoughts in an hour. See you an hour from now.